Hi, I'm Lauren Hankey here with Stephen Chun for another episode of the NRG Oncology podcast. Since November is Pancreatic Cancer Awareness Month, we thought it'd be the perfect time to talk about locally advanced pancreatic cancer and one of the newest NRG oncology trials, NRG-GI011, that was activated earlier this year.
Our guest today is Dr. Nina Sanford, who is an associate professor of radiation oncology and gastrointestinal radiation oncology section chief at the University of Texas at Southwestern Medical Center in Dallas. She's also the national principal investigator of the GI011, which is evaluating the role of escalating radiation doses for locally advanced unresectable pancreatic cancer. Dr. Sanford, welcome to the NRG Oncology podcast. I wanted to start off by asking a couple of basic questions for Pancreatic Cancer Awareness Month. And when we refer to pancreatic cancer in this podcast, I also want to clarify to our audience that we're talking about the type of cancer that arises from the part of the pancreas that produces fat and sugar digesting enzymes, rather than the part of the pancreas that produces things like insulin. Often, pancreatic cancer is called the emperor of all maladies. In the general sense, Dr. Sanford, why is pancreatic cancer so hard to treat? And since the year 2000, cases of pancreatic cancer have more than doubled in the United States. Do you have any sense why we're seeing such a dramatic increase in the number of cases in the past 2 decades?
Hi, everyone. First of all, thank you so much for having me on. So, your first question, why I think pancreas cancer is hard to treat. I think two main reasons. The first is that pancreas cancer is often diagnosed at a later stage. I think 60 to 70% of metastatic cancer at diagnosis, and the cure rate for those patients is very low. And I think the second reason is that even for localized tumors not metastatic, even if their size is small, they can be difficult to resect because of their location around critical blood vessels. And so surgery remains such a critical part of therapy. Without this, the likelihood of long term survival is low. Of course, we think this is a potentially also a place where radiation could play a role, which I know we'll talk about more. With regards to the epidemiology of pancreas cancer, I don't think we know all the causes for why it is increasing in incidence, and I think very concerning. Also, that several studies show, especially a sharper increase in younger patients. But risk factors I have seen implicated are first would be consequences of smoking. Of course, that is now on the decline in many places, including the US. So, mostly this would be a carryover from earlier generations that would affect older populations. I think the second would be lifestyle trends, obesity, diet, and related to that, diabetes and alcohol use. But I think this is an open question, the rising incidence of pancreas cancer, along with many other GI cancers, particularly in younger individuals without obvious genetic risk factors.
So, Dr. Sanford, for your study GI011, we are looking at a specific subset of patients who, on one hand, the pancreatic cancer hasn't metastasized or spread to other parts of the body, but on the other hand, the cancer has grown to the point that, as you discussed, maybe some critical blood vessels are involved and it's no longer safe for a surgeon or possible for a surgeon to remove it. How exactly is locally advanced pancreatic cancer defined for your study, and how good or bad are the current options for it outside of a clinical trial?
These are patients whose cancers are localized and haven't spread, so they aren't stage 4. But of those patients, there really is a wide spectrum of presentation. So, on one end of the spectrum, and this is unfortunately the minority, there are patients with resectable tumors whom a surgeon feels that he or she can remove at diagnosis with clear margins. Our study captures the opposite end, which basically tumors that are essentially unresectable, mostly due to involvement of critical vessels, particularly arteries in that area. There are formal criteria to define this, and the decision is usually made at a multidisciplinary tumor board with review from radiology, obviously surgery, and other specialties. And currently, the prognosis for these patients is poor. Median survival is less than 2 years from diagnosis, so clearly there is a lot of room for improvement. The main standard of care treatment is multi agent chemotherapy at this point. Additional local therapy options, such as radiation, are used, but has not yet been shown to confer a survival benefit in large randomized trials.
So, on this topic of your study GI011, usually we speak to our guests about what the rationale is for their study. But I wanted to take a slightly different angle on this today. I wanted to ask just very plainly, do you remember where you were, what you were doing when you came up with this idea? Like, were you sipping a cup of coffee late one day and light bulb came on? I think there's a lot of people who might not be in medicine in our audience who kind of wonder, how did these people come up with these ideas for study? And then how did you move this idea forward through the cooperative groups from there?
Yeah, so I wish things could happen that quickly, but it was actually really quite a long process from original study, sort of broad conception to trial activation. So I'm part of the NRG Pancreas Working Group. And I think actually it was all the way back in 2021 when the results of the Alliance Borderline trial came out, which I know we'll talk about here in a little bit. And we started to think as a group what would make the most sense to pitch as a trial concept for radiation pancreas cancer. And we thought that the locally advanced disease setting made the most sense since there hadn't been a cooperative trial for these patients that had been completed. And we wanted to test radiation as definitive rather than pre or post operative treatment. I think there were also some promising sort of single institution data coming out and new technologies like MR guided and adaptive radiation relative to that setting. So it was actually first pitched as a phase one single arm concept back in 2022. It was disproved by the committee, the rationale being that there was already sufficient data on safety, such that a phase one trial at the co-op group level didn't really make sense. So then we sort of reconvened as a working group, and that's how we decided to test as a randomized trial. Initially, it was a phase two. Then we got feedback from various committees recommending a more definitive phase three trial. So it was really a long process. But I do think he's sort of, I guess every step helped us refine the trial and importantly, I think garner support from other disciplines and cooperative groups.
With all of that in mind, for our listeners out there who might want to bring NRG Oncology GI011 to their center and patients, can you give us a brief overview of the trial? And what logistical challenges, if any, have you seen thus far that other investigators should be aware of?
So this is a phase three randomized trial testing the addition of dose escalated radiation therapy in locally advanced unresectable pancreas cancer. And I'll define some of those terms a little bit more. But basically, patients start with chemotherapy, which is its standard of care for this disease setting. And then after 4 to 6 months, they get restaging scans and labs. Their cancer needs to have not progressed on scans, and their tumor markers need to have dropped or normalized as well to qualify for that study. And why is that? So, if a patient's tumor marker remains high, we worry they may have occult or hidden metastatic cancer, so intensifying local therapy in that scenario might not make sense. Anyway, so once a patient meets that criteria, they're randomized 1 to 1, meaning half of patients get the experimental, half of patients getting the control arm treatment between either dose escalated radiation or standard of care. A phase three trial always compares the current best standard of care to an experimental regimen. So, dose escalated radiation means, as the name suggests, that it is a high dose of radiation intended to ablate, meaning really eradicate all of the visible tumor, and it can be completed in as short as 5 treatments. The standard of care or control arm includes several options, including more chemotherapy, observation if one has already completed 6 months of chemotherapy, or standard low dose radiation. And those options are really based upon large randomized studies showing no survival difference between the treatments. So we would let the treating team and patient decide what would make the most sense if they're randomized to the control arm. So the primary endpoint, this is how we judge the trial to be successful, is if it improves 3-year overall survival or the proportion of patients who are alive 3 years after randomization. There's also a primary quality of life endpoint as well, which is measured by a patient questionnaire that specifically asks about symptoms affecting patients with pancreas tumors. So this trial just began enrolling, and I haven't heard of specific logistical challenges quite yet. It's still pretty early. I'm sure they will arise, but we have gotten lots of questions regarding sort of inclusion criteria, planning details. So if one does have any questions regarding any of those details, definitely let me know.
As I know you're aware, there have been several prior attempts to bring increased radiation doses to locally advanced pancreas cancer. About a decade ago, we tried to do a study, RTOG 1201, which compared standard with dose escalated radiation for pancreas cancer. But as I recall, the trial was closed after results of LAP-07 failed to demonstrate a clear role of chemoradiation in this setting. And then with 5 treatments of stereotactic radiotherapy, we tried dose-escalated radiation prior to surgery in the Alliance A021501 trial you mentioned earlier, which didn't seem to help either. With this history in mind, how were you able to convince NRG Oncology and the Clinical Trial Evaluation Program, or CTEP, to move forward with GI011? And more importantly, what gave you the fortitude and courage to forge ahead where I would argue that many have failed?
Yeah, as you mentioned, RTOG-1201, randomized trial, local advanced pancreas cancer, launched about 10 years ago, comparing standard dose 50.4 gray to, I'll say, a slightly higher dose of 63 gray, so a bit lower than the dose we're targeting. But my understanding was that it was closed due to slow accrual, which, as you pointed out, might have been related to the LAP100 trial reporting, which was basically negative for standard dose chemoradiation. So that certainly could have dampened enthusiasm for that study. So the Alliance borderline trial, different population, but without getting into the details, also negative. And then PanCRS actually was somewhat similar to our study design, locally advanced, multi-institutional, not cooperative group, but didn't accrue. So no, you're totally right. Historically, radiation hasn't had the best batting average with regards to randomized trials in pancreas cancer and locally advanced pancreas cancer. I guess that being said, I think even despite that, most would agree, even clinicians who might be the most nihilistic toward radiotherapy, that a subset of patients with pancreas cancer and specifically with locally advanced pancreatic cancer do benefit from radiation. And I think this is demonstrated by current practice patterns and the use of radiotherapy in this setting. So I think the question really is, who are the patients that benefit? How do we deliver the radiation? And really, how can we capture or quantify those benefits? So I think when we framed it that way, the powers that be were receptive and encouraging. Plus, I think there has been, since those trials we mentioned had completed or stopped accruing, that there has been promising non-randomized data on the potential of dose-escalated radiation in this setting. And then I guess also, even though those trials were negative or didn't complete, there is a lot that we can learn from them with regards to things that we want to emphasize or maybe do differently in our study. And some of those are to really tailor patient selection to those we think might benefit the most from radiation, hence the tumor marker criteria in our study. Also, to the best of our ability, perform really meticulous radiation quality assurance. We know that not all radiation is delivered the same way, particularly in pancreas cancer. And I think the third, also, which could be a whole conversation in itself, is to try to pick endpoints that we think really realistically radiation can improve and are also patient-centered in pancreas cancer. And I think the 3-year overall survival and quality of life we think are meaningful for these patients. So I think with all of that, we're really motivated to try to move forward with this study. But, obviously we'll see how things go.
I'm really enthusiastic about this trial, and I think that although Stephen pointed out some of the, I don't want to call them missteps, but some of the slowdowns, I guess, in progress with radiation related pancreas trials in this space, it seems that now it's actually just really the right timing, and that as a field, we've learned enough, I hope, about how to deliver, as you said, high quality radiation. The technologies have advanced to maybe enable ablative radiation to be a bit safer. And I'm actually glad that a trial like this didn't happen, maybe 5 or 6 years ago, because I think it is better served that it's happening now when we're just that more knowledgeable about how to do it well. One of the other really interesting things that's come out in the locally advanced pancreatic cancer space, just presented a few months ago at the 2025 ASCO annual meeting, was the PANOVA-3 trial, which essentially showed a survival and quality of life benefit from adding low frequency alternating electrical fields or tumor treating fields. What's your take on this data? And if FDA approved, will alternating electrical fields like the PANOVA-3 trial be allowed in GI011? And would that require an amendment to the trial to account for potential effect of tumor treating fields if that happens?
Yeah, so PANOVA-3, a large randomized phase 3 trial that assessed, as you mentioned, the addition of tumor treating fields to chemo with gemabraxane in this exact disease setting. So locally advanced unresectable pancreas cancer. The median survivals improved 14 to 16 months. And then, as you also mentioned, these patients had longer interval without pain, the ones who were assigned to the experimental arm. I think there are some considerations worth mentioning for the study. The chemo was gemabraxane. Of course, that was in both arms. But I think a bigger potential limitation is that could be made about these device studies, particularly these tumor treating field studies, is that when you are assigned to that device, it does come with much more frequent monitoring and attention. So one potential explanation for, potentially better outcomes, particularly better symptoms, is more frequent healthcare interactions in that group. And that could be related to some of the outcomes, but of course that's just a hypothesis. But all that notwithstanding, this is a positive study. I do think that it will probably get FDA approved from what I've heard. So I think we'll see what the uptake of the device is before deciding, how and whether to integrate it into our study. It would require an amendment. As you know, Tumor Treating Fields has been approved for GBM for some time. My understanding is that the majority of centers are not currently using it, but of course, locally advanced pancreas cancer is a different disease setting. The advice on your head is probably different than on your torso. So we'll see. I think at the end of the day, we are very, very open to tailoring and amending our study to both reflect the standards of care and also to maximize patient accrual. I think we really want to balance the best science with feasibility. And what we certainly don't want is to complete our trial and then have a critique be that it is no longer relevant.
Lastly, we've spoken a lot about just how challenging it is to treat pancreatic cancer. And in closing, for 2025 Pancreatic Cancer Awareness Month, I'm wondering if you could just speak to patients out there who might be facing a pancreatic cancer diagnosis, who might even be considering a trial like GI011. What sort of advice and words of hope might you give them?
Yeah, so I guess first, thank you for the time, taking the time to even consider enrolling on a clinical trial. I think with a diagnosis of pancreas cancer, certainly things can feel very overwhelming. First, I guess, know that progress is happening in pancreas cancer, and clinical trials represent such a critical step in moving the field forward. For our trial specifically, it's a phase 3 trial, meaning that all the treatments have had some degree of testing, certainly for safety and also signs of efficacy as well. It's being conducted across hundreds of centers nationwide and is sponsored by the National Institutes of Health at National Cancer Institute as well. And it was really created with support from all disciplines, including patient advocates. And really, in planning the study, we try to consider every aspect from the patient perspective, from streamlining the requirements as much as possible to decrease the burden of study participation. And as also I mentioned before, really trying to actually measure endpoints that reflect what patients and their families with pancreas cancer and their loved ones really value. So we really are grateful for the opportunity to conduct this study, and especially to patients who take the time to participate. And if you have questions about the trial, you can obviously reach out to our study team or me directly as well.
Dr. Sanford, thank you again for joining us on the NRG Oncology podcast. I want to, of course, commend you and also wish you luck on this trial, trying to move the needle forward for our patients with pancreatic cancer who so desperately need better options.
Awesome. Thank you so much for having me on.
For 2025 Pancreatic Cancer Awareness Month, we've been joined by Dr. Nina Sanford, the National Principal Investigator of NRG GI011 for unresectable, locally advanced pancreatic cancer. Treating a fair amount of pancreatic cancer myself, I can personally attest that if any of you out there are interested in opening GI011, Dr. Sanford is highly approachable and helpful for trials and just for patients in general. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks everyone for joining in, and happy clinical trials.